Thank you for your time. I want to start with a simple framing. What we're discussing is not care quality, and it's not technology. It's money specifically, money hospitals lose every year after patients leave. Post-discharge failure has quietly become one of the largest unmanaged financial risks hospitals face. And it's now at a scale where it belongs at this table. Hospitals deliver high-quality care. That's not the debate. The issue is that CMS no longer evaluates hospitals only on care delivered inside the building. CMS evaluates outcomes that occur after discharge. Those outcomes now directly impact reimbursement, public reporting, and reputation. That shift has changed the nature of accountability. This is no longer an operational gap. It's a governance gap. Under CMS value-based programs, especially HRRP, penalties are automatic. They recur every year, apply across all Medicare inpatient claims, and are publicly visible. The majority of U.S. hospitals are penalized annually. Nationally, hundreds of millions of dollars are extracted from hospitals every single year. This is not a temporary policy environment. This is the financial baseline hospitals now operate under. When we bring this down to the hospital level, the numbers become very concrete. A mid-size hospital typically generates $80 to $120 million in Medicare inpatient revenue. Up to 3% of that is exposed annually to HRRP penalties. That is millions of dollars at risk every year. And importantly, that exposure repeats, compounds, and is not appeal-based. CMS penalties are only one side of the loss. Readmissions themselves are expensive events. They consume beds, staff time, clinical capacity, and often arrive with limited reimbursement. Even modest reductions in avoidable readmissions translate into hundreds of thousands of dollars annually. So hospitals are absorbing both a reimbursement penalty and an operating cost at the same time. What's critical to understand is this. The data is very clear that readmissions are rarely caused by poor inpatient care. They are driven by what happens after discharge: missed medications, confusion, missed follow-ups, delayed intervention. This is not a failure of effort. It is a failure of execution at scale. The moment a patient is discharged, hospitals lose daily visibility into what actually happens. Patients go home. Behavior becomes the variable. Compliance becomes uncertain. Yet financial accountability does not disappear. Hospitals remain responsible for outcomes they no longer actively manage. That gap between responsibility and control is where the losses occur. Hospitals have tried to close this gap with existing tools. EHRs are systems of record, not systems of execution. Patient portals are passive and depend on initiative. Staffing-based follow-up doesn't scale. Static discharge instructions don't change behavior. And staffing shortages make the problem worse, not better. Hospitals are penalized for execution, but equipped for documentation. Briea exists specifically to solve that execution gap. We are not an EHR replacement. We don't disrupt existing systems. Briea is a post-discharge care execution platform. Our role is to ensure that care plans are actually carried out once the patient leaves. That is the missing capability in the current hospital stack. One of the reasons hospitals continue to struggle is time horizon. Risk does not stop at 7 days or 30 days. Many failures surface weeks or months later. Briea manages post-discharge care over a full year for surgery recovery, chronic disease, and long-term stabilization. Discharge summaries become living, adaptive care plans. Critically, Briea does not wait for patients to act. We initiate engagement on specific dates and times. Medication reminders, labs, follow-ups, all scheduled and proactive. Patients don't need to remember. Hospitals don't need to chase. Execution becomes systematic instead of incidental. Briea operates fully across voice, text, and WhatsApp. There is no dependency on app installs or digital sophistication. This matters deeply for elderly patients, rural populations, and low-bandwidth environments. Engagement improves without adding staff or friction. Another silent driver of readmissions is misunderstanding. Discharge instructions are often not truly understood. Language and literacy gaps matter. Briea communicates in the patient's language and reinforces understanding over time. This directly improves adherence and supports equity outcomes CMS now tracks closely. Bria's AI is not reactive chat. It reasons over time. It interprets discharge context, patient behavior, and missteps. Follow-up intensity adjusts automatically. Escalation happens only when risk rises. This replaces manual monitoring with scalable intelligence. All of this has a human consequence. Post-discharge failures generate follow-up calls, crisis management, and recovery work. This consumes nursing and care coordination capacity. Briea absorbs much of that downstream workload automatically. That protects staff, reduces burnout, and stabilizes operations. There is also a spillover effect hospitals often overlook. When clinicians trust post-discharge execution, they discharge earlier and with more confidence. Even small reductions in length of stay unlock significant capacity and revenue. This benefit alone can be material at scale. When we aggregate all of this, penalties avoided, costs reduced, capacity improved, the financial impact becomes clear. Even under conservative assumptions, mid-size hospitals see millions of dollars in annual benefit. And importantly, this impact repeats year after year. This is not speculative. These are known cost centers becoming controlled variables. At this point, this is no longer an IT conversation. It is about revenue protection, risk governance, operational control. Hospitals are already paying for post-discharge failure. Inaction is not neutral, it is expensive. CMS penalties are tightening, not easing. Staffing relief is not coming. Patient behavior has become a financial driver. Hospitals that continue with static tools will continue to absorb loss. Boards that act gain control. Briea converts post-discharge risk into financial control. We help hospitals execute care beyond discharge, systematically, proactively, and at scale. This is not about adding complexity. It's about eliminating failure. We would welcome the opportunity to partner with you.